Class, I'm Eric Carpenter, and this week we're going to be discussing medical care systems worldwide. Next slide. International comparisons. This chapter will provide comparisons on the healthcare delivery systems between the United States and 6 major countries: Canada, France, Germany, Japan, Switzerland, and the United Kingdom. One common problem between all 7 countries is controlling growth in medical care spending. Next slide. Table 14.1, Key Statistics, provides several key statistics comparing population, economics, and health for the U.S. and the 6 countries discussed in this chapter. The U.S. has the largest economy as measured by gross domestic product, and healthcare spending is significantly higher in the U.S. than in any other country. Next slide. Health system classification. There are 4 basic models: NHI, Bismarck, Beveridge model, and mixed. NHI, or National Health Insurance, also referred to as single payer, is characterized by government-run national health insurance. Bismarck was first developed in Germany and provides universal insurance coverage through not-for-profit insurance companies selling mandated benefit packages. Beveridge model, characterized by government ownership of the medical infrastructure. And the U.S. uses a mixture of the above-mentioned models. Next slide. Table 14.3, Classification of Health Systems. This provides a summary of 9 key characteristics relating to healthcare delivery. Next slide. Canada, National Health Insurance Medicare. Canada's national health insurance system delivers high-quality medical care to all at about half of the per capita cost of U.S. healthcare. Features for Canada include provincial health plans be publicly administered, they're portable across provinces, universal coverage, accessible, comprehensive first dollar coverage of all medically necessary services. Next slide. Most physicians paid on fee-for-service basis and have practice autonomy. Most Canadians have supplemental insurance that covers dental, vision, and prescription drugs. Financing of healthcare spending in Canada for 2011 is 70% federal government, 12.3% private insurance, 14.7% patient out-of-pocket expenses. Key strategies are regionalization of high-tech services, global budgets for hospitals. One of the downsides of Canada's national health insurance system is they have wait lists for some medical services. There was a court ruling that the ban of private insurance was deemed unconstitutional. Next slide. France. Equality, liberty, fraternity. There is a potential for conflict between these goals. Sickness funds equals mutual aid societies. The term laissez-faire means allowed to do. GNHI, or General National Health Insurance, covers 83% of French workers, with remainder covered by other occupational funds. Financing primarily from social insurance, but with private insurance supplement. Next slide. Financing for France is employer pays 12.8% of employee's salary. Employee pays 0.75%, and there's a social contribution tax of 5.25%. All employees covered by French Social Security legislation and must contribute to the national social security system. There are 4 branches: life and health insurance, occupational disability insurance, old age pension, and family leave. Features for France include universal coverage. Patients pay large copayment, may pay whole bill, then seek reimbursement of 75 to 80% of prescribed fee. Exception for low-income patients. Patients pay copay for hospital, 20%, lab tests, 30%, dental, 30%, prescription drugs, 35 to 65%, and 100% of non-covered drugs. In France, the introduction of new technology is much slower. Next slide. Germany, sickness funds. After World War II, Allies divided Germany into 2 separate countries: East Germany, socialist, and West Germany, used pre-war economic system including healthcare. 1990, East and West Germany united by treaty. 16 provinces. West Germany laws apply. Health insurance and provincial responsibility. Provincial social solidarity. Government must provide access. Citizens contribute according to their ability to pay. Features in Germany include universal coverage, all required to have health insurance. Those earning below a threshold, $65,000 in 2011, must join a sickness fund. Those earning above may get private insurance. About 10%, mostly civil servants, have comprehensive private insurance paid by their employers, giving better access. Premiums for workers in sickness funds based on income, not age or dependence. Next slide. Private insurance covers more, creates competition, spurs use of technology, and ensures that care gap between public and private is small. Germans receive high quality hospital and ambulatory care, prescription drugs, dental care, and disability income benefits, but public health services and psychiatric services are minimal. Since 1977, 40 laws to control costs, co-payments were added, and per capita spending fell. Dual systems for physicians in the hospitals. Next slide. Japan. Since World War II, Japan has high life expectancy, low infant mortality rates. Japanese society almost free of crime, pollution, and other social problems. A much lower incidence of alcohol consumption, AIDS, drug abuse, etc., etc. Population density in Japan is over 12 times that of the U.S. In history, there's mutual aid associations. The Constitution, public health is a national responsibility. Next slide. The financing for Japan is for GMHI, 8.2% payroll tax paid by employer and employee. Other plans have to have other financing. Co-payments vary between 10 and 30%, capped at $800 a month for the average family. At cost of 9.5% of GDP, Japanese will receive comprehensive benefits for all legal residents. Preventive care, medical procedures not associated with onset of disease not covered. Medical services on a fee-for-service basis using national fee schedule revised biannually. Hospitals paid based on diagnosis. New hospitals in urban areas prohibited. Waiting times increasing. Japanese have an extreme aversion to invasive treatment. Surgical rates are low. Next slide. Switzerland. Individual responsibility in a federalist framework. Swiss model has avoided link between health insurance coverage and employment, relying instead on personal responsibility. Insurance sold per individual, group, and family plans do not exist. Healthcare spending, 11% of GDP, second only to the United States. Medical resources highest in Europe. Permanent residents must purchase health insurance. If they refuse, they're assigned to a plan. Generous package of services included. 40% purchase supplemental policy. Insurance provided by 90 private insurers operating on a not-for-profit basis. Each canton governs own and financed through taxes. Individuals pay community rated premiums. Policies have 6 different deductibles. Next slide. 2 types of managed care plans. One like staff model HMO, and the other a GP network. Hospitals paid on a DRG basis. Prospective risk adjustment subsidies funds that have higher costs due to adverse selection. Theoretically, physicians compete for patients, insurers compete for customers, and insurers compete for primary care physicians. Swiss system, a reasonable alternative to government-run insurance plans in Europe. Mandate to purchase insurance with benefits defined by government. Coverage automatic at birth and guaranteed renewable, covering all pre-existing conditions. All expected to contribute something to purchase and subsidize when cannot afford. And this is a good model for the U.S. to use for reform. Next slide. United Kingdom. Single payer concept and limited supervision. Providers kept administrative costs low, but from start, NHS underfunded and dominated by medical community. Healthcare delivery politicized led to a series of crises, one every 3 years, between government and medical practitioners. A goal of NHS to eliminate inequalities, increase facilities in underserved regions, and restrict expansion in overserved regions, but still up to 40% difference in spending across regions. Anyone requiring elective procedure, not life-threatening, put on a waiting list, 1% of the population. Those who can buy private insurance do, which is 12%. Number of hospital beds has declined from 480,000 in 1948 to 182,000 in 2011. In 1993, Thatcher reforms instill market, but incentives weak. Competition did not work. High organizations became independent. NHS trusts. Many GPs became fund holders. By 1995, healthcare provided through NHS trusts. A 2-tiered system developed. 1997, NHS reorganized for the 5th time in 25 years. Next slide. Blair reforms to remove market placed GPs in primary care trusts, each receiving a fully capitated budget to provide all health services for a defined population. There's a 10-year plan included promise of more hospitals, physicians, and cleaner facilities. Health inequalities have widened. Even so, public supports equal access by 2-to-1. In 2010, Tory coalition plans to reform NHS 6th time. 5-year plan to rebuild administrative structure of NHS. phase out primary care trust by 2013. There's money set aside for primary care, who will go to newly created GP consortia to purchase CareLike HMO. Plans short on details will require much legislation. The risk of creating a tax-funded system where a small number of GP consortia control half of the NHS budget. Next slide. The question I have is, from the healthcare system discussed in the chapter, which country has the best one in which the United States could use as a model for reform? Please explain why. Thank you. Have a great day.